I'll be providing an overview on diarrhea, starting with the definition, talking about the different types of diarrhea as they're traditionally taught, and then talking about diarrheas according to the causes of the diarrhea. So infectious and gastroenteritis, malabsorption, secretory causes, inflammatory bowel disease, and some others. This will be a pretty quick overview. I'll get into some detail, but there are a lot of causes and a lot of diseases, so I'll go through those pretty quickly. So first, let's start with the definition. Diarrhea is defined as frequent, loose, or watery stool. Now, frequent is kind of subjective. This is all relative to their normal. I guess a good baseline might be more than 3 times a day, or if you were to measure it, which nobody does, more than 200 grams of stool a day. This Bristol stool scale was developed, which I think is pretty helpful to visualize what the consistency of your stool looks like and what might be considered diarrhea. So in the middle, or what would be considered normal, would be something in the middle, like a 4 or a 5, maybe 3, 4, or 5. Those are better consistencies. A 4 is like a sausage shape or like a snake, kind of like soft serve ice cream. Anything a little bit harder than that might be a type 3. Even more hard, something lumpy, kind of hard on its way out, is a type 2. Separate hard lump, like little rabbit poos, is a type 1. That would be severe constipation. The other end of the spectrum, if they're soft blobs that are like lacking edges, that's a type 5. Mild diarrhea would be type 6, where it's mushy with ragged edges and still kind of connected, but if it's not connected at all, it's type 7. So diarrhea is really type 6 and type 7 on the Bristol stool scale. So this is helpful to kind of visualize what we're talking about. It's not just mushy blobs, it's mushy blobs that aren't really connected anymore. And you can add all kinds of things to this. You can add blood, you can add mucus, you can add white blood cells, and we'll talk about how that varies. So this is the way that diarrhea was taught, and still is taught. They kind of divided it into these categories: secretory diarrhea, osmotic diarrhea, which includes malabsorption, inflammatory diarrhea, and exudative diarrhea. I'll give some examples of these and talk about them individually. Secretory diarrhea is usually when the ion channels in the bowel lumen are disrupted, and they either cause increased secretion of ions or decreased absorption of ions. So somehow the ions end up in the bowel lumen, and water follows those ions, and oftentimes other ions follow those ions. So if a negative ion leaves and is in the lumen, a positive ion might follow, and water will follow as well. There's usually no structural damage to the epithelial cells. There's just ions and water passing through, and that creates diarrhea. One example of this is cholera, which stimulates chloride ion secretion. The body responds by secreting sodium, and water follows sodium, and then you have a bunch of salt water in your bowel, which creates the diarrhea. You have watery stools. There are several other causes of this, like rotavirus. C. diff does this by producing a toxin. Carcinoid does it. Gastrinoma, VIPoma, they all create secretory diarrheas. To diagnose this, you can take a stool sample. You should see no fat in your stool. You should see no blood in your stool and no white blood cells. You can measure the stool osmolar gap, and that'll be less than 50. And I don't know why I put this twice, but there should be no fecal fat. Next is the osmotic diarrhea and malabsorption. This is when there's some high concentration of some osmol, and that draws too much water into the bowel. Now, that osmol can be anything. It could be sugar, it could be salt, it could be fat, it could be artificial sweetener. So if you eat too many sugar-free gummy bears and they have some artificial sweetener that acts as an osmol, it might draw too much water into the bowel and make you poop yourself. Same thing if you have fat malabsorption. If you're missing a pancreatic insufficiency, and you can't absorb the fat can act as an osmol and draw too much water into the bowel, also causing a diarrhea. Other examples: lactase deficiency, celiac and tropical sprue, Whipple's disease, and as I mentioned, consuming sugar-free food, drinks, or gum can all cause osmotic diarrheas. To diagnose this, you can do a fecal fat, and that fecal fat can be positive. You can have a increased stool osmotic gap above 100. So the equation for this, I mentioned it earlier, but the equation is plasma osmolality minus 2 times the stool sodium and the stool potassium. So if that comes out to be over 100, you should suspect an osmotic diarrhea. One way to differentiate secretory from osmotic is that the osmotic diarrheas will go away when the person stops eating. So if you stop eating the gummy bears, or if you stop eating the fatty foods, if you don't have a pancreas, if you stop eating the whatever Diet Pepsi that's causing you to have poops, the osmotic diarrhea should stop. So these typically, if they're caused by something that you're eating, they might not happen at night. They might not happen if you start fasting. Next is the inflammatory diarrhea. This is when you have explicit damage to the mucosal lining or the brush border, and exudative diarrhea, which is when you have oozing of blood, mucus, pus, or plasma protein into the stool. Some examples of inflammatory and exudative, I kind of group them together because these examples are kind of mixed, are IBD, inflammatory bowel disease, so Crohn's and ulcerative colitis. Some infections can cause this, bloody diarrheas. Ischemic colitis, diverticulitis, radiation colitis can cause this as well. To diagnose this, you can again take a stool sample. This time you'll see blood, you'll see white blood cells, and you'll see mucus. And that might prompt you to do a colonoscopy as well. Now, I drew circles around these, and these circles are intentionally overlapping. So my point here is that the cause of diarrhea might not be just secretory. It might be a mix of secretory and inflammatory. You'll have all kinds of combinations. So this is helpful to understand the pathophysiology, but know that the diseases can be mixed and aren't necessarily fitting into these categories perfectly. So that being said, on the previous slide, I said these were the causes of diarrhea. This is how I organize it in my head. Diarrhea is so widespread that I think it's probably best to know both ways of organizing it. Organize it according to pathophysiology, but also know that they can mix. So there's a lot here, but let's start with infectious and gastroenteritis. So these are infectious causes of diarrhea. First, big dividing line is, are there any alarm symptoms? So these alarm symptoms would be abdominal pain, fever, blood, pus, if it's been diarrhea that's been going on for a while, more than 3 days, if the person's immunocompromised, if they're dehydrated, if they recently traveled, took antibiotics, or were recently hospitalized. If you can say no to all of these, then the cause of diarrhea is likely viral. Now, there's a lot of viruses that cause this, like adenovirus, norovirus, enterovirus, rotavirus. The treatment for viral gastroenteritis is usually just supportive. So you'll rehydrate them, start with oral rehydration, and then proceed to IV if it gets really bad. You can give them loperamide just to slow the bowel movements. The brat diet is recommended. This is just generally bland food that isn't going to exacerbate their bowels while it's clearing that viral infection. It stands for bananas, rice, usually white rice is better, applesauce, and toast. And as I mentioned, it's usually self-limiting. You can just wait it out if it's viral. If you say yes to these alarm symptoms, that kind of can be anything else. And there's a lot of other things that can cause infectious diarrhea or gastroenteritis. So it could be bacterial, it could be parasitic. One thing that you always test if somebody has recent hospitalization is C. diff. So you can do a nucleic acid amplification test, and if that's positive, then you would suspect C. diff. Now, C. diff is a normal flora bug that spreads in hospitals and thrives and overgrows other bacteria when the person is on antibiotics. So somebody that's had recent antibiotics, you suspect C. diff. Some people say there's a characteristic smell. I've heard some like ER nurses that talk about that. I don't think that's held up in studies. So maybe we should remove this, but it smells bad, like any diarrhea smells bad. If you do an endoscopy, you'll see pseudomembranes, but you usually don't do that to diagnose it. CBC, you might have leukocytosis. You can diagnose it by doing this nucleic acid amplification test that I mentioned. There's also a toxin that you could use to diagnose it, but the NAAT is used more frequently. The treatment, you can either do a PO vancomycin or metronidazole. Now, metronidazole is a little bit older of a medicine to be treated, to be used for C. diff. Vancomycin's a little more expensive, but I think it's more effective as well. Fidaxomicin also works as well. In severe cases where it's not responsive to antibiotics, you can consider a fecal transplant. And if it's very severe, it can become systemic, cause a toxic megacolon and sepsis type picture. And in that case, you want to use both IV metronidazole and PO vancomycin. So the reason for the PO vancomycin is that it'll clear everything in your gut. And the IV metronidazole will be clearing everything in the bloodstream, the septic picture. So that kind of covers both the inside and the outside of your body. So that's C. diff. Next, if you don't have C. diff and you do a stool study and you have positive blood, positive leukocytes, positive lactoferrin, person has a fever, you've ruled out inflammatory bowel disease, then you might suspect an invasive cause of gastroenteritis, an invasive infectious diarrhea. So there's a lot of causes for this. Let's go through them one by one, and I'll tell you the highlights for each of them. Salmonella, this is a bacteria that's commonly found in raw poultry or raw eggs. It can cause osteomyelitis in people with sickle cell anemia. The treatment for this is mainly supportive. If it doesn't go away on its own, then you can consider antibiotics. Shigella is another bacteria. This causes hemolytic uremic syndrome. It's similar in pathophysiology to TTP, thrombotic purpura. So it causes an anemia. There's a microangiopathic hemolytic anemia that results in schistocytes, so you might see that on blood smear. You'll also see a thrombocytopenia. The clot formation causes reduction in platelets, and you can have renal failure that leads to a uremia. Another bug that causes this Shigella Hemolytic Uremic Syndrome is E. coli. So there's a Shigalike toxin that comes from an enterohemorrhagic E. coli, the O157H7 subtype, and that has similar symptoms. It causes the anemia, the thrombocytopenia. It's actually a more common cause of hemolytic uremic syndrome than Shigella is. This will come from uncooked hamburgers. The diagnosis for EHEC is, again, kind of made similarly. You can do a Shiga toxin assay. You'll have schistocytes on a sphere. And the treatment for this is, again, supportive. You can add steroids, plasmapheresis, dialysis. Usually you want to stay away from antibiotics because they can increase the risk of precipitating hemolytic uremic syndrome, but they can be used in very, very severe cases. But usually it's steroids, plasmapheresis. Entamoeba histolytica, this is a protozoa. It's common in people that are immunocompromised, so people that have HIV/AIDS, people that recently traveled to Central or South America. This can progress to liver disease. It can cause like a liver abscess, and that person would present with right upper quadrant pain and an abscess seen on imaging. To diagnose this, you can do a stool antigen or a serology for the bug, and the treatment for entamoeba is metronidazole. Next is Campylobacter jejuni. This is the bug that causes diarrhea that precedes Guillain-Barré syndrome, which would present with ascending weakness, dysarthria, respiratory weakness. The treatment for Guillain-Barré syndrome is IVIG and plasmapheresis. The bug itself that causes diarrhea usually is self-limited and clears on its own. Next, you have Vibrio parahemolyticus. This is associated with cruise ships and shellfish. Vibrio vonificans is also associated with marine things like oysters. People that have liver disease like cirrhosis or hemochromatosis are at higher risk for these three, actually, for Vibrio parahemolyticus, Vibrio vonificans, and Yersinia. Vibrio vonificans is also worth knowing because it can create a necrotizing fasciitis that can lead to septic shock. Lastly, on this list, Yersinia also has an affinity for iron, so it's associated with hemochromatosis. So people that either have a genetic predisposition to hemochromatosis or have had recurrent blood transfusions are predisposed to Vibrios and Yersinias. So let's say you did this test, you've gotten this far, you did your stool studies, and you don't have any blood in the stool, you don't have any white blood cells, you don't have a fever, there are no ova and parasites on the stool study. You might suspect the person has a non-invasive enterotoxic infectious gastroenteritis. So this is a little more mild, usually no blood in the stool. So let's go through this list very quickly. Vibrio cholera, I mentioned this one earlier with a secretory diarrhea, but this is something that creates a rice water diarrhea and vomiting with dehydration. They'll have symptoms of dehydration like muscle cramps, sunken eyes, and dry skin. The treatment here is to essentially replenish water. It's not the bug itself that'll kill people, it's the hypokalemia and the acidemia that'll be more harmful. You want to keep these people fed, and you can use doxycycline to clear the bug. EHEC, your enterotoxic E. coli. This is also known as Montezuma's revenge. This is a common cause of traveler's diarrhea. It can come from tap water when you're abroad, or unwashed vegetables or street food when you're abroad. The treatment here is supportive. You can use ciprofloxacin, which is empiric for traveler's diarrhea, but sometimes it clears on its own as well. Make sure these people stay hydrated. Next is Giardia. This is a protozoa. The classic story is a camper that went to drink unfiltered fresh water from a stream. The bug itself can incubate for like a week or two, so they might have a camping trip a week or two ago and then present with diarrhea like this. The diagnosis is a stool antigen, which is better than microscopy. On microscopy, you would see the oocytes and trophocytes, but usually you use the stool antigen. Treatment for Giardia is metronidazole. These next two, Staph aureus and B. cereus, they're mostly vomiting predominant, but they can also cause diarrhea. They're two causes of food poisoning. What they have in common is that the toxin is made before the food is ingested. So Staph aureus comes from proteinaceous foods like egg salad that was left out at a hot picnic. The Staph aureus can create a toxin as it sits out in the heat, and that toxin makes you have diarrhea and also makes you vomit. The treatment is supportive, keep them hydrated. B. cereus, also vomiting predominant. It comes from like reheated rice. So the classic story is leftover Chinese food. You can get it from buffets, from food that's been sitting out for way too long. This one has a bit more of a delay, 1 to 6 hours after ingestion. Treatment is again supportive and hydration. Last one, cryptosporidiosis. This is a protozoa, also in immunocompromised people. AIDS with a CD4 less than 100. The diagnosis for cryptosporidiosis is acid-fast stain, so like tuberculosis, but it's causing diarrhea. The treatment is nitrogen oxide and ARTs, because if their CD4s are that low, they should be getting the antiretroviral therapy. So that was a lot, but those are the infectious causes. Again, diarrhea is a very common complaint, and there are some associations that are worth knowing when they have diarrhea and something else. So if a person comes in with diarrhea and descending paralysis, you should think about Clostridium botulinum. If they have diarrhea and meningitis, you can think about Listeria. Diarrhea and cellulitis, or diarrhea and sepsis, think about Vibrio vulnificans. That's the, mentioned it here very briefly, that's the necrotizing fasciitis that can lead to septic shock with Vibrio vulnificans. Diarrhea and jaundice could be hepatitis A virus. So there's a lot more things that cause diarrhea than what I listed here, but these are some associations that are worth knowing. Okay, so the next category of causes is malabsorption. So another long list. I'll give you the highlights for each, and hopefully the things that are most worth remembering. So celiac disease, pathophysiology here is the person has an allergy to gluten. They have antibodies that destroy the villi inside the gut, and you can actually see this on EGD biopsy, although you don't necessarily need biopsy to make the diagnosis. The symptoms are chronic diarrhea, bloating, abdominal pain, and distension. Some people will be able to relate to these symptoms to actually consuming some gluten-heavy food like bread. They might have weight loss. They have malabsorption of several things. So if they malabsorb iron, they might be anemic, and that can also make them, fatigued, have pallor. If they malabsorb calcium, they can have osteoporosis. They can have dermatitis herpetiformis, which is a papulovesicular rash on the knees, on the extensor surfaces. So it could be on the knees, it could be on the elbows, but that's a classic association with celiac disease. The best diagnosis is made with the anti-tissue transglutaminase, the anti-TTG antibody, as well as the anti-endomysial IgA. Note that you won't have this anti-endomysial IgA in people that are IgA deficient. So TTG might be the best way to start looking for celiac disease. You can also biopsy to confirm that on biopsy, as I mentioned, you'll see loss of surface area and villus blunting. The treatment for celiac disease is to stop gluten in the diet and give it time. After about 3 or 4 months or so, all the symptoms should resolve, the malabsorption should be better. So stop gluten and wait. Next, malabsorptive diarrhea is tropical sprue. This one is common in the Caribbean, Puerto Rico. It's caused by an infection. Clinically, it's similar to celiac disease, and on biopsy, you'll see blunted villi. That's how you make the diagnosis. Stopping gluten doesn't help in this case. So you stop gluten, you wait 3 to 4 months, and it's not getting better. What you do next is give them antibiotics. You give them tetracycline, give them Bactrim, the sulfamethoxazole trimethoprim. So if a person comes in with suspected celiacs and they have a vague history of going on vacation to the Caribbean, they might have this infection, tropical sprue. Give them antibiotics, tetracycline. Next is Whipple disease. This is more rare than celiacs. The pathophysiology here is this bug, T. whipplei, and the symptoms it causes are kind of diarrhea plus. So you'll get the malabsorption, the steatorrhea, that's greasy poos from malabsorbing fats. You'll also have joint pain, arthralgias, fever, lymphadenopathy, dementia, causes some eye complaints as well. So diarrhea, but many other things. The diagnosis is made with this periodic acid Schiff stain, might be called PAS positive stain on the macrophages, and you'll do that on EM or EGD when you get a biopsy. You can also do a PCR for the T. Whipple. The treatment for Whipple's disease is doxycycline and Bactrim. Next is lactose intolerance. The pathophysiology of that is you're missing this enzyme lactase, and that means that you can't digest lactose, which is in dairies like cheese, ice cream, and milk. This means that if the lactose can't be digested, it'll have an osmotic effect in the gut, so it'll draw water into the gut, and the bacteria have a party with it. They consume lactose, they break it down, they can create a bunch of gas. This tends to be worse with age. All humans tend to reduce the amount of lactase that we have as we age, and there's some predisposition in Asians as well, so that kind of explains why a lot of Asian foods don't have as much cheese or milk or dairy products. The symptoms here are bloating, smelly farts, and diarrhea. Diagnosis can be made clinically by doing your elimination diet, so stop all intake of lactose, and if it gets better, that might be a sign that you have lactose intolerance. The treatment is to continue doing that. Stop dairy. You can also take supplemental lactase enzymes, so if you're about to have ice cream and you know it's going to mess you up, you can take lactase enzymes. This can be a primary disorder, which is kind of what I've been describing with this lactase enzyme deficiency. It can also be secondary to intestinal damage. So say you have like a gastroenteritis from whatever other bug. Sometimes your gut needs time to replenish the lactase that it has at the brush border, and that can take weeks to replenish. So if you have lactose intolerance just after having a stomach bug, it might be a secondary lactose intolerance to the damage. That should get a little better with time. Next is pernicious anemia. The classic patient here is somebody that's old that has other autoimmune diseases like type 1 diabetes or vitiligo or hypothyroid. Autoimmune hypothyroidism. The pathophysiology is an antibody against the parietal cells and intrinsic factor in the stomach. So these cells and intrinsic factor help aid the absorption of vitamin B12, and this results in a vitamin B12 deficiency. The symptoms you'll have with pernicious anemia are the symptoms of vitamin B12 deficiency. So you'll have macrocytic anemia, you can have glossitis, a big shiny tongue, you can have the neuro symptoms, the weakness, numbness in the legs. The diagnosis is made by actually confirming the B12 deficiency. So that's, again, on your CBC, you'll have a macrocytic anemia, you'll have high homocysteine, high methylmalonic acid. That's how you know it's B12 and not folate deficiency. You can check for antibodies as well against the parietal cell or the intrinsic factor. There's this old test called a Schilling test that they used to do, where they would kind of look at the pathway for B12 absorption, and they would individually test each part of that pathway. That's not really used as much anymore. We tend to use the B12 deficiency picture as well as the antibodies themselves. The treatment for pernicious anemia are to replace vitamin B12. Next is short bowel syndrome. Essentially what's going on here is that you've had most of your small bowel removed. This could be from surgeries, from trauma, from Crohn's disease. And because you've had so much of your small bowel removed, you have a malabsorption where you're not able to intake all of these nutrients that end up in your gut, and then these nutrients can have an osmotic effect and pull water and cause diarrhea. You'll present with diarrhea, you'll present with weight loss because you're not absorbing all your nutrients. You'll also present with deficiencies in many of your vitamins and minerals. So for instance, if you have a deficiency in vitamin D, you can have osteoporosis. A deficiency in vitamin E, you might have nystagmus. Deficiency in vitamin A causes night blindness, and deficiency in vitamin K causes bleeds. In addition, you can have deficiencies in B12, iron, calcium, magnesium, zinc. The treatment for this is you can give loperamide to kind of slow the gut. That might help with the absorption a little bit. You can also endorse having smaller meals. You can also endorse having lower fat diets, and you can also give supplements if that might help people absorb what they're missing. Lastly, there are some medications that intentionally induce malabsorption. A couple examples: orlistat is used for weight loss. It inhibits lipase, so you're intentionally not breaking down the fats in your diet, which causes you to have steatorrhea. So you're essentially pooping out all the fat that you're not absorbing. Really messy, really crude way to lose weight. Alpha-glucosidase inhibitor, similar but for carbs, so this inhibits carbohydrate absorption. This is used, I think, for diabetes, and this causes gas, it causes bloating, it causes diarrhea. So you can intentionally induce malabsorptive diarrhea. Shorter list here for the secretory diarrheas. First, there's carcinoid. This is a small intestine tumor that can metastasize to the liver. Remember, everything from your gut goes through the portal system to your liver, and it can secrete serotonin into the blood. So the symptoms that you'll get in addition to secretory diarrhea are flushing, wheezing, right heart problems. This is in contrast to the carcinoid of the lung, which would go to the left side of your circulatory system. So it'll go into your systemic system. You can diagnose secretory diarrhea by finding this high amount of 5-HIAA. This is a breakdown product of serotonin. So if you have a carcinoid tumor that's secreting serotonin into the blood, you'll also expect to have high 5-HIAA in the urine. You can also do imaging to find the tumor. The treatment is ultimately resection, but you can give octreotide to help with symptoms in the meantime. Another tumor that causes secretory diarrhea is gastrinoma, also known as Zollinger-Ellison syndrome. The pathophysiology here is that you have high levels of gastrin and high gastric activity. You have an extremely acidic stomach. Your stomach's usually pretty acidic, but this is even more than usual. So much so that it inactivates lipase, which means that you can't break down your fats, and you end up with a diarrhea. You end up with peptic ulcer disease as well. The diagnosis can be made by measuring gastrin levels. If your gastrin is above 1600, you very likely have a gastrinoma. If your gastrin is below 250, you very likely don't have a gastrinoma. You should explore other causes of your diarrhea. If your gastrin is between these numbers, you can do a secretin stimulation test. This is where you give the person secretin, which in normal physiology would decrease the amount of gastrin. But if they have a gastrinoma, it'll increase the amount of gastrin. And it's important to make sure the patient stops taking their PPIs, their proton pump inhibitors, before doing this test. So if you have a gastrin that's between 250 and 1600, and you do your secretin stimulation test, and gastrin increases even more, that diagnoses gastrinoma. You need to look for it and remove it surgically. This also predisposes you to gastric cancer, so it's not something you want to just leave and forget about. Next is VIPoma. This is another tumor that causes a secretory diarrhea. The pathophysiology here is that it's a tumor that secretes vasoactive intestinal peptide, VIP, and this increases electrolyte secretion and relaxes smooth muscles and sphincters. So you can kind of see the other symptoms based on this pathophysiology. If it relaxes smooth muscle sphincters, it'll cause flushing, it can cause nausea, vomiting, diarrhea, muscle cramps. It can decrease your potassium, cause achlorhydria. The diagnosis is made by measuring a high VIP level, and you want to look at the pancreas because that's where they usually are. You treat this with somatostatin, just like carcinoid, but eventually you want to do a surgical resection for this as well. Next, the inflammatory bowel diseases. So two big categories. They're taught as being distinct, Crohn's disease and ulcerative colitis. A lot of times in practice you have a mixed picture between these two. So I'll kind of talk about them based on these characteristics here. So first, demographics. Crohn's disease happens in young people and old people, so ages 20 to 30, and ages 50 to 75. And ulcerative colitis tends to happen in younger people only. Symptoms. They both cause diarrhea, but slightly different. Crohn's disease causes a watery diarrhea, could be steatorrhea, whereas ulcerative colitis causes a mucus-like bloody diarrhea. They both cause pain, sometimes in different locations, sometimes just generalized. Ulcerative colitis is usually in left lower quadrant. Crohn's disease is usually crampy right lower quadrant, but they could be mixed. They could be different. The origin of Crohn's disease is in the terminal ileum, which makes sense. That's why it causes right lower quadrant pain. Origin of ulcerative colitis is in the left lower quadrant. Now, you can do a biopsy, and you should do a biopsy to diagnosis, and they do have different inflammatory patterns, both grossly and both under microscopy. In Crohn's disease, you'll see patchy skip lesions. You can see cobblestoning, and it can be distributed from your mouth all the way to your anus. It usually spares the rectum, almost always spares the rectum. On microscopy, you can see a non-necrotizing granuloma, and you can see fistulas grossly. So that's when the inflammation gets so bad that it creates a connection between the bowel and other parts of the body. So you can have a bowel to the skin fistula, you can have a bowel to the bladder fistula, you can have bowel to other bowel fistulas. And this can cause peritonitis, it can cause pain, it can cause leakage of fecal content, depending on the area that's affected. Now, ulcerative colitis is typically more localized. It's a continuous inflammation. I said it starts in the rectum, so it's always in the colon, and it kind of spreads from the colon, spreads from the rectum through the rest of the colon. The colectomy is curative for ulcerative colitis because it's so localized, but it's still inflammatory and it still increases your risk of colorectal cancer, much more so than Crohn's disease does. So ulcerative colitis tends to be more localized. It's only mucosal. It's shallow and superficial. On colonoscopy, you'll see friable pseudopolyps, whereas Crohn's disease is transmural, extends into other tissues, can cause fistulas. If you do an X-ray for these two, you'll see a string sign on Crohn's disease. That's the bowel lumen becoming really thin. For ulcerative colitis, you'll see a lead pipe colon picture. I mentioned this earlier, fistulas are common in Crohn's disease. They're rare in ulcerative colitis, which typically just affects the mucosa and is not a deep inflammation. It's a shallow, superficial inflammation. Both of these are inflammatory conditions and are associated with other inflammatory conditions. Crohn's disease is associated with ankylosing spondylitis. Ulcerative colitis is associated with primary sclerosing cholangitis, as well as some P-ANCA conditions. They're both associated with erythema nodosum, iritis, and uveitis. Smoking makes your Crohn's disease worse, but actually decreases your risk of having ulcerative colitis flares. Of course, that doesn't justify smoking. There's many other bad health effects of smoking, but interesting that it affects these two diseases differently. Treatment. Some parts of the treatment are the same, like the anti-inflammatories that you'll take. So for mild inflammatory bowel disease, you can take a 5-ASA compound like sulfalazine, and this is essentially an aspirin variant that breaks down in the gut in the right places to reduce inflammation. It tends to work better for ulcerative colitis than for Crohn's disease. For moderate disease, you can use immunomodulators like 6-mercaptopurine and azathioprine. In refractory cases, you can escalate to methotrexate. And for flares, you can use prednisone. You shouldn't be using this for chronic use. It'll cause Cushing syndrome, but for intermittent use, you can use prednisone. You also want to rule out infection and give antibiotics if they do have an infection. People with Crohn's disease are less likely to get, not less likely, they have not a significant increase in risk for colon cancer, so they don't necessarily need increased colonoscopy screening. People with ulcerative colitis do have a significantly increased risk for colorectal cancer. So these people will need annual colonoscopies 8 years after diagnosis. And again, colectomy is curative for ulcerative colitis. And that makes sense because it was kind of limited to the colon. It started in the rectum, it spread throughout the colon continuously, but was limited to there. So colectomy would fix your issues. In Crohn's disease, you still might need surgery for the fistulas, but you will not have surgery to remove the colon, because then the disease can just pop up in your small bowel or in your esophagus. It can affect any part of your GI tract. So that's inflammatory bowel disease. Good to keep the two separate in your head for board exams, but know that the actual clinical presentation might be more of a mixed picture. Lastly, almost done, we have kind of a grab bag of others that didn't fit into any of the other categories. We'll go through these pretty quickly. There's radiation enteropathy and also radiation proctitis. So this is radiation damage, kind of iatrogenic. It damages the anorectum. In the acute case, you'll have diarrhea, mucus, tenesmus, which is an unsatisfactory emptying of the bowels. In the chronic case, you'll have hematochezia, anemia, strictures, fibrosis that can eventually lead to neovascularization, telangiectasias. This happens months to years after radiation treatment. So this will be somebody who gets chemotherapy and radiation for some cancer, and then they'll have trouble with their bowels afterwards. Next is ischemic bowel disease. This is vascular disease that leads to kind of your MI equivalent of the gut. So you can have an embolism, you can have just ischemia, you can have atherosclerosis in your gut vessels. So it's the equivalent of a stroke. It's just infarction of the gut. The mesentery dies. One big risk for this is AFib, because that'll throw clots down to your mesenteric arteries. Symptoms here are bloody diarrhea. They'll have abdominal pain, postprandial angina of the gut, which makes sense. As soon as you start eating, your gut needs to go to work. If it doesn't have the blood supply to go to work, that can cause an angina type pain. And usually the pain is out of proportion to the exam. So the questions stem where the patient might actually present with terrible pain, but then when you go to do the exam, they have minimal tenderness, if any tenderness at all. The diagnosis is made with an angiogram. They'll have high white blood cells and high lactic acid. That's a byproduct of ischemia. Treatment, you might need an XLAP, you might need to resect the dead sections of bowel. You can stent, you can re-anastomose the bowel around the dead sections. Hyperthyroidism can cause diarrhea. You'll have other symptoms like heat intolerance, weight loss, palpitations, diaphoresis. They can be extremely hungry, they can be hyperactive, they can be restless, staying up all night, exophthalmos, tremor, warm skin, your typical hyperthyroid symptoms, but diarrhea is one of them. Irritable bowel syndrome, this is kind of a rule everything else out disorder. It's associated with stress and other functional disorders like interstitial cystitis and fibromyalgia. Tends to be more common in younger people in their 20s and 30s, and I think women more than men. It's worse in pregnancy. Symptoms include intermittent cramping, diarrhea, constipation. It can alternate between diarrhea and constipation. There's a diarrhea subtype and a constipation subtype and a mixed subtype of irritable bowel syndrome. One kind of characteristic feature of this is that the pain is relieved with a bowel movement. So they might have eaten something that hurts them, but then when they poop it out, they get a little better. So maybe a trigger from food, maybe a trigger from stress, who knows. The diagnosis is made, it's a diagnosis of exclusion, so you rule out all the scary things. You might do a colonoscopy, you might, see that there's no blood in the stool, no alarm symptoms that I mentioned earlier, so that'll be how you make the diagnosis. The treatment is really just reassurance, general lifestyle things, exercise, diet, relieve their symptoms. There are a lot of medication side effects that include diarrhea, so a lot of antibiotics, anti-inflammatory, and chemotherapies can cause diarrhea, so keep that in mind if you're trying to work up somebody's case of diarrhea. The patient can present with factitious diarrhea, maybe to lose weight, maybe to want to be a patient, maybe to want to get medical attention. They can just be taking a bunch of laxatives. You can also have people that do this to others, people that do this to their elders. They give them laxatives or induce diarrhea. So that's something to keep in mind. Colon cancer, fecal impaction. You can have a fecal impaction that creates a hard impacted stool, but then they can have fecal incontinence around the stool. So that can be a mixed picture as well, even though it sounds like it might only cause constipation. So this was longer than I thought it would be, but it's an overview of diarrhea. I hope it was helpful. Thank you for listening.